My name is Cameron Elder, and for my presentation, I'll be discussing treatment and tracking strategies for pediatric acute lymphoblastic leukemia patients. Firstly, ALL is a cancer of the blood and happens to be the most common childhood cancer, currently making up roughly 40% of all cases in children. The U.S. sees roughly 6,000 new cases each year, with the peak incidence occurring in 3 to 5-year-olds. In summary, treatment for ALL is long and intensive. It's made up of 2 protocols, including a multitude of heavy drugs and steroids that have many side effects in children, including an eventual weight gain after that initial loss of weight at the onset of treatment. Secondly, treatment is very long. In total, to get to the first remission, treatment can last approximately 2.5 to 3 years, and when relapse or second leukemia occurs, treatment can continue on for even longer. Overall, the prognosis for this disease has been tremendously improved over the last several decades. With a 15 to 20% relapse rate, prognosis is typically worse the second time around, but if second remission is reached, there's a 50% cure rate. Increased water retention and appetite due to steroids, in addition to a decrease in skeletal muscle mass as a result of chemotherapy, we tend to see an increased incidence of obesity and metabolic syndrome in ALL patients. This obesity has a great effect on prognosis during treatment, and even after treatment can lead to long-term chronic health problems, making obesity one of the only true modifiable risk factors for ALL outcomes. As you can see here, obesity is a continually growing problem in all of America's youth, but especially here in Kentucky. An astounding 20.8% of 10 to 17-year-olds in Kentucky are classified as obese, meaning they lie above the 95th percentile in BMI for age and sex. Currently, treatment dosing and tracking for ALL patients involves measures for body weight, BSA, and BMI. However, by using what is known as multi-compartment body composition analysis, we can potentially improve treatment dosing and tracking both during and following ALL treatment by determining absolute and relative fat and fat-free masses, taking into account aqueous, mineral, and protein fractions of body weight. Due to the availability of pediatric-specific equations, we can use a molecular level analysis to complete 2, 3, and 4-compartment body model composition equations that require the following 3 measures. Therefore, in this study, we aim to compare body comp measures using various modeling procedures and equations. By doing this, we hope to demonstrate the advantages of using these more accurate body comp measures to improve dosing and tracking changes in children with ALL. Further, we believe treatment therapies can be improved by identifying specific changes occurring due to ALL treatment itself, along with behavioral intervention. Digging into the methods of our research, we had 26 non-cancer prepubescent subjects. We statistically analyzed our data using ANOVA with repeated measures to compare the group mean differences. In addition, we determined if there was significant correlation amongst all body composition measures and obtained explained variance using a 4-compartment body composition model as our criteria. First, we took total body weight and standing height to find our BMI. Next, in order to run the various multi-compartment models, we used the BOD-POD to measure total body density, BIA to find the aqueous fraction of body weight, and finally use DEXA scanning to find the total body mineral measures. As you can see in this table describing our data, we found an average BMI for age and sex percentile of approximately 126, meaning this group of children were extremely obese. Looking at each of the different multi-compartment body comp models we utilized for our data, we have Lohmann's 4-comp model, Series 3-comp model, Lohmann's 3-comp model, the DEXA scanning 3-comp model, Lohmann's 2-comp model, and finally Buelo and Clacy's pediatric BIA equations. Each of these different models vary in complexity, as well as which specific compartments they measure versus estimate, depending on their use of BOD-POD, BIA, and/or DEXA scanning. Looking at our results for our subject pool along the 7 different models, they certainly appear to yield similar results. However, they all significantly differed from each other with a 0.05 alpha level, with only a few exceptions. Overall, it should be noted that considering the effects ALL treatment has on children, perhaps Lohmann's 4-comp model or Series 3-comp model may prove most beneficial, considering they factor and account for total body water estimation, which we know fluctuates greatly through heightened water retention caused by many steroids utilized throughout treatment. Moving on to our correlations, we see that all body composition measures were significantly correlated with one another regardless of model. Breaking this down into the different components of percent fat, fat mass, and fat-free mass, the highest correlation for all 3 measures was between Lohmann's 4-comp and Series 3-comp model. Looking now at R-squared, we found extremely high explained variance for each measure with Series 3-comp model, while even the lowest explained variance for each respective measure was also relatively high with Lohmann's 4-comp model as our criterion. In conclusion, body weight, body surface area, and/or BMI provide limited body composition information. Therefore, multi-compartment body composition modeling and analysis may assist in providing greater accuracy to increase treatment effectiveness for pediatric cancer patients. Lastly, body composition selection may be influenced by the patient's initial body composition at the time of diagnosis, as well as the alterations in the fat and fat-free mass during various treatment time points. With any study, there will be strengths and weaknesses, and for this project, the biggest limitation of our study is simply the inability to use ALL subjects for our data. Firstly, for our strengths, this study provides pilot data to direct future research in pediatric cancer patients at the time of diagnosis, throughout their treatment, and beyond. It also demonstrates that the required methods and procedures for multi-compartment body comp analysis can be safely and efficiently conducted in a pediatric population. Further, it demonstrates the ability to conduct similar studies in pediatric oncology patients here at the University of Kentucky. Finally, here are some of our references, and thank you guys so much for listening.